So as we see here, a picture of acne vulgaris as it appears in reality. If we look across, this is what is happening in acne, where you get this sebaceous fluid, and it will build up here, and then it becomes infected by proteobacterium. This infection creates like that kind of pus that you kind of see in acne. And then you get, it says here, you get marked inflammation, scarring. Okay. Anyway, we'll move on to impetigo. Yeah. So impetigo can occur with eczema. Impetigo is a bacterial infection of the skin in children. It's caused by Staphylococcus aureus or Streptococcus pyogenes. Staphylococcus aureus, or Streptococcus pyogenes. It begins with a single spot which quickly turns into vesicles and pustules. It forms a classic gold crust and is extremely infectious. So let's have a look at what impetigo looks like. As we can see from this picture, here is our classic gold crust. And it's extremely infectious. So the treatments are oral antibiotics. Mild impetigo we can treat with topical fusidine, and severe impetigo we can treat with flucloxacillin. Moving on, we go on to viral warts. So, viral warts are caused by HPV, human papillomavirus. They're spread by direct or indirect contact, so for example, swimming pools. Incubation period, where the infection is present but there's no symptoms, is for weeks and even up to a year, or even over a year. Subhanallah. It's contagious, but spread is low risk. So, its incubation period, the period in which the virus is present but there's no symptoms, maybe for a few weeks or over a year. It's contagious, but the spread is low risk. Treatment: there's nothing, i.e., treatment. You can do nothing because it self-resolves, or you can even use duct tape, which is a very interesting treatment, or cryotherapy, which is freezing it. Here is a picture of viral warts, as we can see. We'll then move on to tinea. Okay, so tinea, also known as ringworms. Tinea is a fungal infection that occurs in various sites. It commonly occurs in sweaty areas, the groin or the scalp. The most common organism responsible is Trichophyton rubrum. What a name. The clue to diagnosis is a short history, and it's very itchy. Its appearance is a slowly enlarging annular, scratchy, erythemaceous, reddening of the skin, plaque. So a slowly enlarging annular, scaly erythemaceous plaque with a well-defined edge and central clearing. So I'm going to show you a picture because that is a mouthful. Here we can see tinea. Is tinea or ringworm, and here is a classical form of tinea, where it's a slowly enlarging annular, scaly erythemaceous plaque. So a scaly erythemaceous plaque meaning it's red, and it has a well-defined edge and a central clearing. So slowly enlarging annular, scaly reddening plaque with a well-defined edge and a central clearing. The treatment for this, topical antifungals. So moving on to actinic keratosis. Actinic keratosis, also known as solar keratosis. This came up in previous lecture as well. It's a common sun-induced hyperkeratotic lesion that has a potential to become malignant, a malignant cancer. It affects 23% of the UK population. It occurs due to long-term sun exposure, so incidence increases with age. It's a risk for phototherapy patients and immunosuppressed patients. So it occurs due to long-term sun exposure, and incidence. it occurs due to long-term sun exposure, so its incidence increases with age, as obviously as the older you are, the more you're exposed to the sun for longer, and the more you've been exposed to the sun, and it's a risk for phototherapy patients and immunosuppressed patients. The treatment for this is emollients, cryotherapy, and referral to dermatologist if uncertain of diagnosis, or if it may turn into a squamous cell carcinoma. So emollients, cryotherapy, referral to dermatologist if uncertain of diagnosis, or if it may turn into a squamous cell carcinoma. Here is a clear example of actinic keratosis. Okay. The histology of histology of actinic keratosis. So it's atypical keratinocytes in the lower epidermis. Once it affects the full thickness of the skin, it becomes a Bowen's disease. So actinic keratosis is a atypical keratinocyte in the lower epidermis. Atypical keratinocytes in the lower epidermis. Once it affects the full thickness of the skin, it becomes Bowen's disease. So here is Bowen's disease. As we see Bowen's disease. So Bowen's disease is actinic keratosis. So actinic keratosis is when it's just the top layer of the skin, the epidermis, where you have atypical keratinocytes in the epidermis. However, if it breaches the full thickness of the skin and develops, it becomes Bowen's disease. Bowen's disease is precancerous and an early form of a cancer lesion. So here is an example of Bowen's disease. Okay, now we'll move on to the cancer. So there's three types of cancer we're going to talk about: squamous cell carcinoma, basal cell carcinoma, and melanoma. So we'll start off with squamous cell carcinoma. It occurs on sun-exposed sites, e.g. back of hand, forearm, face, etc. Can occur de novo or from actinic keratosis plus Bowman's. So occurring de novo means it can occur from nothing, or can occur from actinic keratosis or Bowman's. Squamous cells are flat cells in the stratum granulosum. These atypical squamous cells are more likely to invade the dermis and metastasize than basal cell carcinomas. So the carcinoma is surgically removed. So this carcinoma can be surgically removed. Here's squamous cell carcinoma. So as we were saying, these are squamous cells that the squamous cells are flat cells in the stratum granulosum. As we said before, there's 4 layers of the epidermis. Remember, BSGC, not PSG. BSGC. The squamous cells are flat cells in the stratum granulosum. These atypical squamous cells are more likely to invade the dermis and metastasize than basal cell carcinoma. Moving on to basal cell carcinoma. So basal cell carcinoma arises on its own / de novo. The basal cells are the lowest layer of the epidermis in the stratum basale. Also occurs on sun-exposed sites, e.g. head and neck. It's unlikely to metastasize, but basal cell carcinoma are likely to recur. So carcinoma is surgically removed. So the difference between squamous cell carcinoma and basal cell carcinoma. Squamous cell carcinoma, it's likely to metastasize. It's likely to invade other areas of the skin, such as the dermis, and it's likely to metastasize. Whereas the basal cell carcinoma, it's unlikely to metastasize. However, when it's surgically removed, it's more likely to recur. Moving on to melanoma. So melanoma is an atypical... Oh, forgive me, I'm just going to go back quickly to basal cell carcinoma. Here is a picture of basal cell carcinoma. As you can see, there's a clear difference between squamous cell carcinoma, it looks horrible, to basal cell carcinoma. Moving on to melanoma. So melanoma is atypical melanocytes that invade the dermis and the subcutis. So atypical melanocytes that invade the dermis and subcutaneous fat. It's deeper the invasion, the lower the survival rate. So melanoma are atypical melanocytes that invade the dermis and the subcutaneous fat. The deeper the invasion, the lower the survival rate. And here is a picture of melanoma, and we have covered this before. And I'm just going to go on to the final part of this lecture, which is about suspicious features. So there is an order, or a mnemonic, I think that's the word, to be able to help identify suspicious features on cancer. So A, B, C, D, E. Number 1, A, asymmetry, B, border irregularity, C, color variation, D, diameter if it's over 6 millimeters, and E, if it's itching and bleeding. And normally, even if it's bleeding without any itching as well. And here we're going to say other suspicious features if it's bleeding without trauma, or even bleeding without itching, new pigmentation, and new what does that say? New nodules. Cool.